The human body's defense system is, well, this is a marvel, isn't it? Constantly working to keep us safe.
Absolutely.
But imagine if that very system, the one meant to protect us, actually started attacking our own body. That's the complex world we're navigating in this deep dive. Systemic lupus erythematosus, or SLE, a condition where the immune system really gets its signals crossed.
That's right. And our aim here is to give you a really solid, memorable grasp of SLE. Think of this as your go-to audio resource, hitting all the crucial points from comprehensive revision material.
Right.
Just to ensure you have a clear understanding of this condition for when it, really counts.
Exactly. We're sort of on a mission here to build a complete picture of SLE for you.
Yeah.
We'll explore what it is, the definition, then delve into the possible triggers, the etiology, who's more susceptible, so the risk factors, the fascinating but intricate pathophysiology.
Yeah, that's key.
How we tell it apart from other conditions, the differential diagnosis, who it affects epidemiology, what you might actually see in a patient, the clinical features.
The presentation, yeah?
How we investigate it, the strategies for management, what the future might hold, prognosis, and of course, potential complications. Let's get started.
Okay, so let's lay the foundation first with the definition. SLE is a chronic autoimmune disease.
Chronic autoimmune. Got it.
The key here is autoimmune, meaning the body's immune system mistakenly attacks its own healthy tissues, and chronic means it happens over a long period.
And it's not just focused on one area either. It can affect pretty much any organ or system in the body. That's the systemic part, I guess.
Precisely. That's exactly right. The root of the problem lies in the production of autoantibodies. These are like, well, misdirected missiles, if you will, produced by the immune system that target the body's own components. This leads to widespread inflammation and, unfortunately, damage in various tissues.
Okay, so the body's own security force has essentially turned against its citizens.
Wow. Now, what actually sets this whole process in motion? Let's talk about etiology, the contributing factors. Yeah, this is a really interesting area because, well, to be perfectly honest, the exact cause of SLE isn't fully understood. It's not like a simple cause and effect thing.
Right.
Instead, we think it's multifactorial. So a combination of different elements coming together.
Multifactorial, so like a team effort of things contributing. What are some of the key players on that team?
Absolutely. Genetics definitely seems to play a significant role. Certain genes can make individuals more predisposed, more likely to develop SLE.
Right.
Then we have environmental factors, things like infections, maybe some medications, exposure to certain chemicals. These are all suspected contributors. And hormones also appear to be involved, which might be a key reason why SLE is, well, much more common in women.
That naturally leads us straight into risk factors then. We've already mentioned being female is a pretty significant one. What else increases someone's chances of developing SLE?
Well, having a family history of SLE or even other autoimmune diseases is another important risk factor. It suggests there might be some shared underlying genetic susceptibility, We also know about specific genetic markers, like certain types of HLA-DRB1 genes that have been linked to an increased risk.
I think I remember reading something about a C4 gene deficiency.
Yes, exactly. A deficiency in a specific complement protein linked to what's called the C4a null allele has been associated with a higher risk of developing SLE.
Right.
The complement system is part of the immune system, helps fight off bugs, and a deficiency there can sometimes contribute to autoimmune issues.
Okay.
And we also can't forget those environmental triggers we mentioned. Exposure to UV light is a big one for some people.
Sunlight.
Yes. And certain viruses, Epstein-Barr virus is often mentioned, and even some drugs have been implicated in triggering lupus in people who are already susceptible. So it's a really complex interplay of factors.
It really sounds like a perfect storm, doesn't it? Genetic predisposition, meeting the wrong environmental conditions, maybe with some hormonal influences stirring the pot. Okay, let's get into the real sort of engine of the disease, the pathophysiology. What's actually going wrong at a biological level here?
Okay, so at its heart, the issue is a fundamental breakdown in immune system regulation. The normally precise and balanced immune response becomes, well, overactive and starts misidentifying healthy cells and tissues as threats.
And the main culprits in this misdirected attack are those autoantibodies we talked about, especially anti-nuclear antibodies, or ANAs. Is that right?
Exactly. The production of anti-nuclear antibodies, ANA, is a really common finding in SLE. Now, while a positive ANA test alone doesn't automatically mean someone has lupus, it can show up in other conditions too.
Right. Low specificity.
Precisely. But it is present in the vast majority of SLE cases. These autoantibodies, along with other things called immune complexes, then trigger widespread inflammation. And because these can circulate all through the body, they have the potential to cause damage in multiple organs. Think of it like friendly fire, but on a systemic scale.
So we're talking potential damage to the skin, the joints, the kidneys, pretty much anywhere.
Pretty much anyway, yes. SLE can involve multiple organs, leading to things like skin rashes, joint pain and inflammation, kidney problems, which can be quite serious.
Okay.
Heart issues like pericarditis, lung involvement such as pleurisy, and even affecting the brain and nervous system, causing neuropsychiatric symptoms. It's a truly systemic disease with potentially far-reaching effects.
Wow. Okay, with such a wide array of potential symptoms, it must be really challenging sometimes to diagnose SLE. How do doctors differentiate it from other conditions that might present with similar signs? That's where differential diagnosis comes in, doesn't it?
Absolutely, and it's crucial. Because many of the symptoms of SLE can overlap with those of other conditions, it's really important to consider other possibilities. We need to think about other autoimmune diseases that share similar features, like rheumatoid arthritis, systemic sclerosis, Sjogren's syndrome, and various forms of vasculitis, which is inflammation of blood vessels.
And what about those overlap syndromes I've heard about?
Good point. Overlap syndromes are exactly as they sound, conditions where a patient might actually have features of more than one connective tissue disease. So, for instance, someone could present with symptoms that suggest both lupus and perhaps scleroderma.
Okay.
We also need to rule out other things like, say, drug allergies, which can sometimes mimic lupus-like symptoms, and various infections too.
Makes sense.
And it's also worth remembering that people with SLE have a slightly increased risk of developing other autoimmune conditions and certain comorbidities, things like atherosclerosis, hardening of the arteries, and even some types of cancer.
So it's not just about identifying what is SLE, but also carefully ruling out what it isn't, and being aware of potential co-occurring conditions too.
Okay, now let's zoom out a bit and look at the bigger picture, the epidemiology of SLE, particularly here in the UK. How common is it, actually?
Well, in the UK, the estimated prevalence of SLE is around 0.05% to 0.1% of the population.
Okay, so 1 in 1,000 to 1 in 2,000, roughly.
Roughly, yes. So while it's not the most common condition out there, it's certainly not considered rare either.
And we know it affects women more often, especially those in their childbearing years. Are there any other demographic patterns we should be aware of? Any variations?
Yes, there are. The incidence rates do vary across different ethnic groups. We see a higher prevalence of SLE among individuals of African Caribbean descent compared to other ethnic groups here in the UK.
Right, that's important.
It is. It's an important factor to keep in mind for diagnosis and also for understanding potential healthcare disparities. Okay, we get a good understanding of the background now. Let's move on to what SLE actually looks like in a patient. What are the key clinical features that might make a doctor start thinking about lupus?
Well, the first thing to say is that the clinical presentation of SLE is incredibly diverse, which, as we've kind of touched on, can make diagnosis tricky.
Yeah.
No two patients will have exactly the same set of symptoms. However, there are some general features that are quite common, such as persistent and often unexplained fatigue.
That's a big one, I hear.
It is. And fever, mouth ulcers, and swollen lymph nodes, what we call lymphadenopathy.
Okay. And then we have the skin manifestations, which are often quite distinctive, aren't they? Like the classic butterfly rash.
Absolutely. The malar rash, which often takes the shape of a butterfly across the cheeks and the bridge of the nose, is a really well-known sign, very characteristic. Other skin issues include the discoid rash. These are raised, scaly, and sometimes circular patches, often on the scalp or face. And photosensitivity, meaning their skin is unusually sensitive to sunlight and can flare up with exposure.
So sun protection is key.
Definitely. We also see Raynaud's phenomenon, where the fingers and toes change color, white, blue, red, in response to cold or stress. Levato reticularis, which is a kind of net-like purplish pattern visible on the skin, and non-scarring hair loss, or alopecia, can also occur.
What about joint and muscle pain? That seems to be a really frequent complaint in many autoimmune conditions.
That's right. Arthralgia, which is just joint pain, is very common, as is non-erosive arthritis. Now, the non-erosive part is important here.
Oh, right.
It means that unlike in some other forms of arthritis, like rheumatoid arthritis, this type doesn't typically cause permanent damage or erosion of the bones in the joints.
Okay, that's a key distinction. What about the heart?
Cardiovascular involvement can happen. It can include inflammation of the lining around the heart, called pericarditis, or inflammation of the heart muscle itself, myocarditis. And there's a specific type of heart valve abnormality sometimes seen in lupus known as Liebman-Sachs endocarditis.
And SLE can affect the lungs as well, you mentioned.
Yes, respiratory issues like pleurisy, that's inflammation of the lining of the lungs causing sharp chest pain, especially with breathing, and something called fibrosing alveolitis, which involves scarring of the lung tissue, can occur.
And the kidneys, that sounds like a major area of concern.
It is. Kidney involvement is a major concern in SLE. It often presents as proteinuria, meaning protein in the urine, and glomerulonephritis, which is inflammation of the tiny filtering units in the kidneys.
Right.
Sometimes kidney involvement can be quite subtle in the early stages and might only show up as elevated levels of urea or creatinine on blood tests without obvious symptoms initially.
And the brain can also be affected, leading to neuropsychiatric manifestations. That sounds quite serious.
It certainly can be. These
Yeah.
can range from more common issues like anxiety and depression, which are very prevalent, to more severe problems such as psychosis, confusion, or even seizures.
Wow.
Strokes can also occur, sometimes as a result of vasculitis, that inflammation of blood vessels we talked about, or due to the formation of blood clots, especially if someone also has antiphospholipid syndrome.
Okay.
And the list, well, it can go on. Patients might experience weight loss, a general feeling of being unwell, what we call malaise, more extensive oral ulcers, chest pain from various causes, headaches, unusual sensations like pins and needles paresthesiae,
Yeah.
dry eyes, further hair loss, muscle pain, myalgia, joint stiffness, sometimes even joint deformity, although it's typically non-erosive, large mouth ulcers, and vasculitic rashes on the skin. It really highlights the incredibly varied ways SLE can present itself.
It's a really extensive and, frankly, quite overwhelming list of potential symptoms. So how do doctors actually go about confirming a diagnosis of SLE, given all this complexity? Let's talk about investigations. What tests do we use?
Okay. Investigations for SLE typically start with blood tests looking for those key autoantibodies we mentioned earlier.
Right, the ANA.
Exactly. Anti-nuclear antibodies, or ANA, are highly sensitive. That means they are positive in the vast majority of people with lupus, maybe 95% or more.
Okay, so pretty much everyone with lupus has it.
Generally, yes. However, they aren't very specific. They can also be positive in other autoimmune conditions, some infections, and even in some healthy people.
Right.
So while a negative ANA makes SLE much less likely, a positive one definitely needs further investigation. We then look for more specific antibodies like anti-double-stranded DNA, that's anti-dsDNA,
dsDNA.
and anti-Smith antibodies, anti-SEAM. Now, these are less sensitive than ANA, meaning they aren't positive in everyone with SLE, but they are highly specific. A positive result for either anti-dsDNA or anti-Smith is strongly suggestive of SLE.
So a positive anti-dsDNA or anti-Smith is a much more definitive clue towards lupus.
Exactly. They really point towards it. We also sometimes check for other antibodies like anti-U1RNP, SSA, which is also called anti-Rho, and SSB anti-La. These can be associated with SLE and other autoimmune diseases like Sjogren's and can sometimes provide further diagnostic or prognostic information.
Okay. And what about general blood tests?
Alongside the antibody tests, a complete blood count, or CBC, is important. It can reveal abnormalities like anemia, low white blood cell counts, leukopenia, or low platelet counts, thrombocytopenia, which are common in lupus.
Right.
Kidney function tests, checking urea, creatinine, eGFR, are crucial to assess if the kidneys are involved. And we also measure complement protein levels, specifically C3 and C4. These tend to be lower during active SLE because they're being used up in the inflammatory process.
So low C3 and C4 can indicate active disease.
Yes, they can be markers of disease activity.
And inflammatory markers like ESR and CRP, how do they fit in? Are they useful?
They can be helpful, yes.
Huh.
The ESR, or erythrocyte sedimentation rate, is often elevated in active lupus, reflecting inflammation. CRP, C-reactive protein, can sometimes be elevated too, but often less dramatically than ESR unless there's an infection or serositis.
Yeah.
Monitoring ESR and also the levels of anti-dsDNA antibodies can help track disease activity over time.
Okay. Now, when it comes to actually diagnosing SLE, there are established classification criteria, aren't there? You need a certain number of features.
That's correct. There are classification criteria developed by rheumatology organizations that help standardize diagnosis, particularly for research, but also used clinically. A common set involves 11 criteria. A person may be classified as having lupus if they meet 4 or more of these 11 criteria over time, either simultaneously or cumulatively.
11 criteria. That sounds like quite a lot to keep track of, especially under pressure. Is there a helpful way to remember them? Mnemonic, perhaps?
There is. A very common mnemonic used is MDSO brain. It's quite handy.
MDOP brain. Okay, let's break that down.
Sure. So M is for malar rash, that butterfly rash. D is for discoid rash, those raised, scaly patches. S is for serositis, which includes pleuritis, inflammation around the lungs, or pericarditis, inflammation around the heart. O is for oral ulcers, usually painless ones inside the mouth. A is for arthritis non-erosive, affecting 2 or more peripheral joints. P is for photosensitivity, that unusual skin reaction to sunlight.
Okay, MDSO.
Then brain. B is for blood disorders like anemia, low white cells, leukopenia, low lymphocytes, lymphopenia, or low platelets, thrombocytopenia. R is for renal disorder, kidney involvement, shown by persistent protein in the urine or cellular casts seen under the microscope. A is for anti-nuclear antibody, ANA, a positive test. That's usually a prerequisite now in newer criteria. I is for immunologic disorders, the presence of those specific antibodies, anti-dsDNA, anti-SMM, or antiphospholipid antibodies. I is for immunologic disorders, the presence of those specific antibodies. And N is for neurologic disorder, things like seizures or psychosis, where other causes have been ruled out.
MDSO, brain death. That's fantastic. Much easier to recall. So identifying at least 4 of these, with ANA usually being one, strongly points toward a lupus diagnosis. Are there any other investigations that might be considered?
Yes, definitely. Urinalysis is really important and should be done regularly to check for protein or blood in the urine, which can be an early sign of kidney involvement even before blood tests change.
Right. Simple but crucial.
Absolutely. We might also order imaging studies like chest x-rays if lung symptoms are present, or echocardiograms if there's concern about heart involvement. Ultrasounds might be used for joints or kidneys.
Okay.
If there's suspicion of antiphospholipid syndrome, which can cause clots and occur alongside SLE, we'll specifically test for antiphospholipid antibodies like lupus, anticoagulant, and anticardiolipin antibodies.
Makes sense.
And because women with SLE have an increased risk of premature atherosclerosis, monitoring cardiovascular risk factors, cholesterol, blood pressure, glucose is also really essential long-term.
Right.
In some cases, particularly if there's significant kidney involvement shown on urine or blood tests, a biopsy of the affected organ, usually a renal biopsy, might be necessary. This helps assess the exact type and extent of the damage, which guides treatment decisions.
Okay, so diagnosis is a really comprehensive process involving clinical picture, antibodies, blood tests, urine tests, and sometimes imaging or biopsy. Now, once SLE is diagnosed, how do we actually manage it? What are the main treatment strategies?
Well, the main goals of managing SLE are, firstly, to control the symptoms the patient is experiencing. Secondly, to prevent flares, those periods when the disease suddenly becomes more active. And thirdly, critically, to minimize long-term damage to organs.
Right.
It's important to remember currently there's no cure for SLE, so treatment really focuses on effectively managing the condition long-term and improving the patient's quality of life.
Okay. What are the key types of medications used in SLE management? What's in the toolkit?
The main classes of medications include non-steroidal anti-inflammatory drugs, or NSAIDs, things like ibuprofen or naproxen. They help reduce pain and inflammation, especially in joints and muscles, but need careful use due to potential side effects, particularly on the kidneys and stomach.
Okay.
Then we have corticosteroids like prednisolone. These are powerful anti-inflammatory and immunosuppressant drugs. They're often essential for getting flares under control quickly, but we try to use the lowest effective dose for the shortest possible time because of their long-term side effects.
Yeah, steroids have a downside.
They do. Then there are various immunosuppressive drugs, often called disease-modifying drugs, or DMARDs in this context. Hydroxychloroquine is a cornerstone for many patients. It helps control skin and joint symptoms, reduce flares, and might even have long-term survival benefit.
Hydroxychloroquine. Okay.
Other immunosuppressants like methotrexate, azathioprine, mycophenolate mofetil, and sometimes cyclophosphamide are used to dampen down the overactive immune system more strongly, especially when major organs are involved or if hydroxychloroquine isn't enough.
Right. Stronger stuff for more serious cases.
Exactly. And in recent years, we've seen the development of biologic therapies.
Ah, yes, the newer agents, like belamimab.
Precisely. Belamimab is a biologic medication that targets a specific protein involved in the survival of B cells, which are key players in producing those autoantibodies. It's licensed for use in adults with active autoantibody-positive SLE who are still experiencing high disease activity despite standard treatments.
Okay. Are there others?
Rituximab, another biologic targeting B cells, is sometimes used off-license in severe cases. Research is ongoing into other biologic targets as well. And it's really important to stress that patients with SLE should ideally be under the care of a multidisciplinary team.
Right, not just one doctor.
No.
Yeah.
This might include rheumatologists, kidney specialists, nephrologists if the kidneys are involved, skin specialists, dermatologists, cardiologists, neurologists, specialist nurses, depending on which organs are affected. A team approach is best.
What about managing the day-to-day symptoms, like pain? That must be a big part of it.
Oh, absolutely. Effective pain management is crucial for improving quality of life. This isn't just about drugs. Non-pharmacological approaches like appropriate physical activity tailored to the individual and physiotherapy can help maintain joint mobility and reduce pain and fatigue.
Good point. And medication-wise?
For milder pain, paracetamol is often the first-line choice as it's generally safer long-term than NSAIDs. NSAIDs, hydroxychloroquine, or perhaps low-dose corticosteroids might be used for more persistent mild symptoms like joint pain. For more severe flares, especially if there's involvement of major organs like the kidneys or brain, a combination of higher-dose prednisolone and stronger immunosuppressants like azathioprine, mycophenolate, or cyclophosphamide is often necessary.
Right.
And anticoagulation blood thinners like low-dose aspirin, warfarin, or heparin might be needed in certain situations to prevent blood clots, particularly if the patient has antiphospholipid antibodies or a history of clots.
Are there any important non-prescription management strategies that people with SLE should definitely be aware of? Things they can do themselves?
Absolutely. Sun avoidance is really critical for many people with lupus because exposure to ultraviolet UV light, even through windows sometimes, can trigger disease flares, especially skin rashes, but sometimes systemic flares too.
So high-factor sunscreen is a must.
Definitely. We strongly recommend the regular use of high-factor, broad-spectrum sunscreens, SPF 50+, ideally, and wearing protective clothing like hats and long sleeves, even on cloudy days. Maintaining a healthy lifestyle, generally avoiding smoking, regularly gentle exercise when possible, a balanced diet, getting enough rest is also important for overall well-being and managing fatigue.
And what about things like contraception and pregnancy? I imagine these are really important considerations, especially as SLE often affects women of childbearing age.
They certainly are, and need careful discussion. The use of combined oral contraceptives containing estrogen needs to be approached with caution in women with SLE, particularly if they have antiphospholipid antibodies or active disease, as estrogen can slightly increase the risk of blood clots. Progestin-only methods or long-acting reversible contraceptives are often preferred.
Okay. And fertility. Pregnancy.
Generally, fertility itself is not significantly affected by SLE, although some treatments like cyclophosphamide can impact fertility. Pregnancy is often possible, especially when the disease is well controlled beforehand. However, pregnancy in women with SLE does carry higher risks than usual.
What kind of risks?
Particularly if the lupus is active, or if there's kidney involvement, or if the mother has certain antibodies like anti-Ro or antiphospholipid antibodies. These risks can include disease flares during pregnancy, early pregnancy loss, preeclampsia, high blood pressure in pregnancy, restricted growth of the baby, and premature delivery.
So planning is key.
Absolutely. It's generally recommended to plan pregnancies for periods when the disease has been stable and well controlled for at least 6 months, ideally on pregnancy-compatible medications. For women with antiphospholipid syndrome and a history of miscarriages or clots, treatments like low molecular weight heparin injections and low-dose aspirin are often recommended throughout pregnancy to reduce risks.
Okay. What about really severe cases? Are there other options?
In very severe, life-threatening flares of SLE, perhaps with rapidly worsening kidney failure or severe neurological involvement, a procedure called plasma exchange, or plasmapheresis, might be considered to rapidly remove harmful antibodies and immune complexes from the blood.
Right. And vaccinations.
We generally advise that people with SLE should receive an annual flu vaccination and the pneumococcal vaccine. However, live vaccines like MMR or the yellow fever vaccine should generally be avoided, especially in those on significant immunosuppression, as they could potentially trigger infection or a disease flare.
And neuropsychiatric SLE. Does that require specific management?
Yes, managing neuropsychiatric SLE can be complex. If the symptoms are thought to be directly related to lupus inflammation in the brain or nervous system, treatment often involves high-dose glucocorticoids and other immunosuppressive therapies. If neuropsychiatric symptoms are thought to be linked to anti-phospholipid antibodies causing small clots or strokes, then antiplatelet or anticoagulation medications are usually necessary. It often requires careful investigation to determine the cause.
Finally, the British Society for Rheumatology provides guidelines on managing SLE based on how severe the condition is, right? Can you summarize that approach?
Yes, their recommendations offer a framework based on disease severity, often categorized as mild, moderate, or severe. For mild SLE, typically affecting skin and joints without major organ threat, the initial approach often involves hydroxychloroquine, perhaps methotrexate, and short courses of NSAIDs or low-dose steroids for symptom relief.
Okay, mild is manageable then.
Often, yes. Moderate SLE might involve more persistent symptoms, maybe some mild organ involvement, or not responding fully to first-line treatments. This might require higher doses of prednisolone initially, and the addition or optimization of other immunosuppressive drugs like azathioprine or mycophenolate.
And severe?
Severe SLE involves life-threatening or organ-threatening manifestations like severe lupus nephritis or central nervous system involvement. This necessitates thorough investigation to pinpoint the problem and often requires high-dose intravenous or oral prednisolone, more aggressive immunosuppression with drugs like cyclophosphamide or mycophenolate mofetil, and potentially biologic therapies like rituximab or belimumab, intravenous immunoglobulin, IVHI, or even plasmapheresis in critical situations.
So it's a very personalized, tailored approach to managing SLE. Really adapting to the individual and the specific way the condition is affecting them at that time. Now, shifting gears slightly, what about the long-term outlook? What's the prognosis for someone living with SLE?
Yeah, the prognosis for SLE, it can vary quite a bit. It depends on several factors, including how severe the disease is when it's diagnosed, which organs are affected. Kidney and brain involvement tend to carry a worse prognosis, and crucially, how well the condition is managed with treatment over time. While SLE is definitely a chronic condition, often with periods of increased activity, the flares, and periods of remission, it's important to stress that many individuals with SLE can lead active and fulfilling lives with appropriate medical care and self-management.
That's good to hear.
It is. However, we do have to acknowledge that the potential for irreversible organ damage and the development of complications can significantly impact the long-term outlook and quality of life for some.
And we have some specific data from the UK regarding this, don't we? It's quite sobering.
Yes. While survival rates for people with SLE have improved dramatically over the past few decades thanks to better treatments.
Okay.
Studies in the UK still indicate that, on average, individuals with SLE may unfortunately have a reduced life expectancy, perhaps around 25 years less compared to the general population. The mortality rate is estimated to be around 10% over a 20-year period following diagnosis, with the average age of death being approximately 53 or 54 years.
Wow. And kidney disease is a major factor there.
It is a major factor in mortality and morbidity. Sadly, a significant proportion of individuals with SLE, maybe around a third in the UK, will develop lupus nephritis, kidney inflammation. And this carries a substantial risk of progressing to end-stage renal disease, needing dialysis or transplant, and contributing to premature death.
Do we know the numbers on that?
For those who develop lupus nephritis, it's estimated that about 20% might progress to end-stage renal disease within 10 years of their lupus diagnosis. And for those who reach end-stage renal disease due to lupus, the mean age at death is tragically young, around 40 years old.
Gosh.
These figures really highlight the seriousness of SLE, particularly when the kidneys are involved, and they absolutely underscore the critical importance of early diagnosis, regular monitoring, and effective, consistent management to prevent that irreversible damage.
Those are indeed sobering statistics and really drive home why proactive and consistent management is just so vital. Finally, let's just briefly touch on the potential complications that can arise from SLE. We've mentioned organ damage quite a few times throughout.
Yes, complications of SLE are often best thought about based on the specific organs or systems affected. As we've just discussed, kidney damage or glomerulonephritis leading potentially to kidney failure is a really significant concern.
Right.
Other potential complications include various cardiovascular issues. There's an increased risk of premature atherosclerosis, leading to heart attacks and strokes, even in younger individuals. Pericarditis, myocarditis can also occur.
Lungs.
Different types of lung problems can arise, like pleurisy, pulmonary hypertension, or that fibrosing alveolitis we mentioned, and neurological complications ranging from cognitive issues or mood disorders to seizures and strokes.
Okay.
Also importantly, due to the underlying immune system dysfunction and the use of immunosuppressant medications, individuals with SLE have an increased susceptibility to infections, which can sometimes be serious.
That makes sense.
And, as we touched on earlier, pregnancy in women with SLE can carry increased risks for both the mother and the baby, which is another significant complication to manage carefully. Regular monitoring for the development of these organ-specific issues and proactive management strategies are absolutely crucial elements of long-term care for individuals living with SLE.
So to kind of bring it all together, SLE is, well, it's a complex autoimmune condition, isn't it? With a really wide range of potential ways it can manifest and with outcomes that can vary significantly between individuals. It's clearly a condition that requires careful, sometimes challenging diagnosis,
Definitely.
a highly tailored approach to management, and really vigilant ongoing monitoring for those potential complications. Thanks so much for walking us through all the key aspects of SLE today. It's been really insightful. For those of you listening who want to really solidify your understanding and maybe access more high-yield revision content on this and other conditions, be sure to check out passmsra.com.
And for even more valuable resources, including things like practice questions perhaps, to support your learning and revision in this area, don't forget to visit freemsra.com as well.
Great stuff. Thanks again for joining us for this deep dive into systemic lupus erythematosus. We really hope this has provided you with a clear, comprehensive, and hopefully memorable overview. It's a fascinating but challenging condition, and it's encouraging that ongoing research continues to improve our understanding and treatment approaches. Until our next deep dive, keep exploring and keep learning.